Just before we start today, a reminder of some of the postgraduate programs that we run here at ScHARR. We have an MPH PG diploma and an MSc PG diploma and PG in clinical research, and we will very soon be launching a similar version of that program, a little bit different, but an online version of it. We have our MPH program. We also have an online version of the MPH program. And coming up on the 25th of January, we have an online event for our campus-based master's courses. They're just 1 hour events, much like this in Blackboard Collaborate, where you can learn more about our master's diploma and certificate programs and our CPD offering as well, if you're interested. I'll put some of those links in the chat in a moment. We also run short courses at ScHARR, so these vary between sort of half a day and 2 or 3 days. The ones that are coming up fairly soon are a new one on creating digital accessible teaching materials, which is partly taught by Dan, who's on the call today with us. And then we've got our systematic approaches to searching for evidence. That one's been running for quite a few years now and is always really popular. Rapid review methods, again, we've been running that one for a long time, but always sells out. And then a face-to-face program. Many of our short courses run online, but we have a 2-part course on psychometrics that runs over 2 days, and that one is taught face-to-face. There is a new episode of our Communicable Research podcast available. Episode 16 is with Professor John Brazier, although I think he's soon to be probably Emeritus Professor John Brazier because he retired at Christmas. But that's him talking about kind of looking over his career in health economics and looking ahead to the future as well. Coming up in the mini masterclass series over the next few months, our next one is with Professor Steve Goodacre talking about clinical risk prediction. Steve's a really, really great speaker. He really simplifies things as well. So if you're looking at a topic like this and thinking, oh, will it be, maybe a bit too complex for me, or I don't really know a lot about this, I promise you he'll explain it in a really brilliant, accessible way. So it's a really good one to come along to. And then we have Michelle Black. Michelle Black will be talking about best start in life, then what? That one will be in March, and Steve's will be in February, because we do one of these every month. So that's the next couple of months coming up in the masterclass series. But today we have Katie Biggs talking about making trials more inclusive. Katie joined the CTRU, the Clinical Trials Research Unit, which is part of ScHARR, in March 2010. I didn't realise quite how long you've been here, Katie, having graduated from both Edinburgh and Liverpool in psychology-related subjects. She previously worked in mental health services as a support worker before joining the CTRU, where she went on to become the lead trial manager in 2015, and then in 2020 she became assistant director of the CTRU. So she's responsible for the management of the CTRU in collaboration with the CTRU director, and is responsible for coordinating the CTRU's input into pandemic research. Katie also teaches across the range of programs that we offer in ScHARR, including our Masters in Public Health, our Masters in Health Services Research, and our Masters in Clinical Research. Her research interests include quite a lot of work with children, including children with autism spectrum disorder. And at that point, I'm going to hand over to you, Katie. Just a moment.
Thanks, Claire.
Just need to swap over there.
It's always a shock when someone reminds me how long I've been here.
Okay, that should be ready for you now.
Great, thank you, Claire. So welcome to my webinar on making trials more inclusive, which is focused on what researchers can do when designing and conducting trials. The webinar is focused on trials and the inclusion of groups experiencing socioeconomic disadvantage, but I do also look at the development of complex interventions and discuss other underserved groups. So I hope you can take something away from this, regardless of your field. As Claire gave an introduction, I've got a little bit more of one, not much. I'm one of the assistant directors at Sheffield Clinical Trials Unit in ScHARR. I develop proposals for trials with clinicians and oversee the project management of those trials if and when they're funded. They're usually randomised controlled trials and funded by the National Institute of Health and Social Care Research, or the NIHR. As a unit, we do not specialise in a particular field. Our trials are quite varied, covering lots of populations and disease areas. Since starting in trial management over 12 years ago and being involved in the oversight of several trials, I've developed a lot more of an interest in trial methodology, which is research into how we design and conduct trials. I'm more than halfway through a pre-doctoral fellowship funded by the NIHR, which is to help me train and develop my research skills in trial methodology, and the focus of my fellowship is inclusion of trials of complex interventions. To start with, I'll provide a short background to inclusivity in trials, the Include framework, and particularly the Socioeconomic Disadvantage framework. This will be short as I want to focus on what can be done to improve our trials rather than the barriers. I will focus on groups experiencing low socioeconomic status. I may get a bit tongue-tied over that word at times, so just as long as you know what I mean, it'll be okay. We are giving another webinar on the Socioeconomic Disadvantage framework on the 21st of Jan, which will include more on how it was developed and how to use it. I'll then go through some of the findings of one of my trial methodology projects, the Access projects, which ends with some recommendations for how trials can be designed to improve inclusion. I'll also discuss some findings from another scoping review I'm doing on the inclusion of groups with low socioeconomic status in the development and evaluation of complex interventions. Overall, these findings include recommendations for how we can include underserved groups in trials and other research, and I'll discuss what I think the next step should be for researchers and organisations. I want to get used to the different clicks. So, research shows that participants in clinical trials rarely reflect the populations that could benefit from the treatments being investigated. I imagine you all know this, and that's why you've joined the webinar, so I'm not going to go into too much detail, but it particularly came to light at the start of the pandemic, where COVID-19 was shown to disproportionately affect older people and those from ethnic minority backgrounds, but they were underrepresented in the research. There are several negative consequences of trial participants not reflecting the populations that will be treated with the interventions being tested. So the benefits and harms highlighted in the trial might not be representative of those observed in the population. Acceptability and adherence might vary across the groups, and the research could be missing important findings to groups of people. More consideration is now being given to how we make sure clinical trials are inclusive populations. And in 2017, the Include project was commissioned by the NIHR to explore underrepresentation in clinical trials. It identified a range of underserved groups which can vary across the types of studies, disease or condition being studied. For example, older adults, 80 plus particularly, and people that lack capacity are routinely omitted from dementia research, where they should clearly be included. There are some common barriers to trial participation in underserved groups, such as research burden, language and communication differences, and a lack of trust and engagement in healthcare or research more broadly. Following from this, the Include Ethnicity Framework was developed to help researchers to think about how the design of their trial and the interventions might limit inclusion of different ethnic minority groups. Since the first framework, two more have been developed, one for the inclusion of people with impaired capacity to consent, and one which I worked on for the inclusion of people experiencing socioeconomic disadvantage. There is also a group working on a framework for sex, gender and sexuality as underserved groups in healthcare research. I'll go through the frameworks a bit more on the next slide. Here I've highlighted my links to the Trial Methodology Research Partnership, although there are written Trial Management Research Partnership. It is Trial Methodology Research Partnership, and the Inclusivity Group, which is one of the trial conduct working groups funded by the MRC, a Medical Research Council, and the NIHR. It's a network of trial researchers with an interest in inclusivity. I found being part of this group incredibly useful, knowing what's going on in the area. I also led to the work on the Socioeconomic Disadvantage Framework, and to my collaboration on Access project, which I lead, and also how I linked with one of my supervisors for a pre-doctoral fellowship. And my pre-doctoral fellowship includes a scoping review on how groups experiencing socioeconomic disadvantage have been included in research into the development and evaluation of complex interventions, which I'll discuss more later as well. So these pieces of funded research and quite a few other projects that I'm aware of shows that funders are keen to address these inequalities in research, and they're now asking researchers how they aim to include underserved groups in their projects. Unfortunately, as researchers, we are used to doing trials in a certain way, and we're not exactly sure of the best way to improve representation. So to start with, I'm just going to go through these, some of the include frameworks. The include framework started with the Ethnicity Framework. This work was led by Sean Treweek from the University of Aberdeen, who also co-led the Trial Methodology Research Partnership before, he doesn't anymore. And the TMRP decided to work on some other frameworks. Two are now available via the Trial for website as well. All frameworks include the 4 key questions listed here and should be considered along with the appropriate patient and public involvement. Now, you do need to have a bit of an idea of the answer to question 1 to identify the appropriate patient and public involvement at early stages, but you can always add representation from other groups later on if it's needed. Question 1 is probably the most important when thinking about inclusion, and one researchers have not really been doing properly. Researchers need to think about what groups incur the most disease burden, and if any groups are often underserved in their field of research. Getting a sample representative of the national population is one thing to aim for, but if the condition being studied occurs disproportionately in particular groups, which it often does, then this would not be representative of the population burden. Question 2 asks you to consider how the treatment being tested may lead to different outcomes or engagement in groups identified. You should consider prevalence, severity, and presentation across groups, and how different groups might perceive or respond to the disease or treatment differently. Question 3 relates to how the intervention or comparator, including how they're delivered, make it harder for some people in the community to take part in the trial. How might the people delivering the intervention, the mode of delivery, the location, the intensity of the treatment limit the involvement of different underserved groups? Question 4 relates to trial design elements. These are eligibility, recruitment methods, trial communication, consent processes, data collection methods and instruments, retention methods, benefits and harms, and analysis and dissemination, and how you designed all of those things might limit participation. The focus on these frameworks is identifying the barriers to relevant underserved groups, and there is existing published research into the barriers of some underserved groups. For example, Wahid's 2015 review highlighted barriers for British South Asians in the UK, and they vary and include patient factors such as mistrust and health literacy, practical issues such as time off for research appointments, family and communicator-related issues such as the role of stigma, health service related issues such as access to healthcare, and then the trial design related as again the inclusion criteria, consent process, outcome measures being in English. Each of the include frameworks follow the same 4 key questions, and there are worksheets breaking the key questions down into different elements of trial design to help researchers consider how they may affect participation. These frameworks can be a lot of work, and there's similarity across them. So if you design trials, I recommend looking at all of them to start with, using the most relevant one to your research, but noting any key aspects from other frameworks where appropriate. There is some work being done in Aberdeen on combining these frameworks to make them a bit easier to use. We already know that there's huge time pressures when designing research, and this can be seen as a very large job, but it is important to get right. The Ethnicity Framework has a lot of detail about its development and some examples of its use on the website. And similarly, the Impaired Capacity to Consent Framework is hosted on a website with a range of resources relating to the inclusion of those with the impaired capacity to consent. I'm going to briefly go through the background to the Socioeconomic Disadvantage Framework and help guide thinking about inclusion in related to socioeconomic status. So socioeconomic status is difficult to measure and report, even if most people roughly know what it means. It's the social standing or class, and class is particularly relevant in Britain, apparently, of an individual or a group, and has a number of domains. It's often measured as a combination of education, income, and occupation. It's not something you can see. It can change over a person's lifetime and is not routinely recorded in healthcare records. Researchers often use postcode as a proxy to socioeconomic deprivation. There are limitations to this. For example, rural areas, postcode covers a huge geographical area. And in inner city areas, the first part of the postcode can cover a huge range of housing types. When developing the socioeconomic framework, we use the 3 Ps, which refers to pockets, prospects and place. Pockets refers to income and economic resource availability, prospects to expectation and life chances, and place to housing and the local environment, including access to sort of local resources. And we use the 3 Ps as a way for researchers to break down a range of potential barriers that a person experiencing socioeconomic disadvantage could face. And indicators of low socioeconomic status are provided here in these categories. In developing the framework with the stakeholder groups, these 3 Ps have been adapted from the UK government's child poverty strategy. The Socioeconomic Disadvantage Framework is designed to consider the inclusion of those experiencing socioeconomic disadvantage. But as you can see in the bottom of the middle box here, there is intersectionality of low socioeconomic status with several other underserved groups. It's linked to a lot of other inequalities, and our public stakeholder group considered this to be an important factor. That there are usually other issues that people are dealing with at the same time. And thinking about this may help with the inclusion of other underserved groups when using this particular framework. The list of indicators in these boxes could be used to help identify people experiencing socioeconomic disadvantage, diversify the PPI, think about potential recruitment settings, as well as identifying barriers to retention. These frameworks should help identify barriers to participation for underserved groups, which is already an improvement on continuing to just do trials the same way all the time. And as you identify these barriers with patient and public partners, you are likely to also identify potential solutions or ways to address the barriers. There is existing literature on overcoming some of the barriers. There is largely US based. They're a little bit ahead of us in terms of this because the FDA made put some guidance out about diversity in trials, so they're a little bit ahead of us. There are differences in the research practices and cultural systems between the US and the UK and Ireland. So many of these activities may not be applicable to the UK and Ireland, whether a result of the different underserved populations or the activities themselves reflecting different research and cultural practices and healthcare systems. As a result, we put together the Access Project. It's funded by the NIHR Clinical Trials Unit's efficiency funding, which is looking at trial methodology. It's exploring what activities are currently being done and what more could be done potentially to overcome the barriers in the UK and Ireland. There are 4 stages of the project. We're currently in the last stage, but I'm going to report on the other 3 stages to provide you with some potential solutions to barriers for trial entry for underserved groups. So the 4 packages were a scoping review, roundtable discussions, trial redesign meetings and interviews around implementation. Through a discussion with collaborators following the initial scoping, we decided to focus on 4 underserved groups for inclusion in the review that are listed here: socioeconomic disadvantaged backgrounds, ethnic minority backgrounds, those that lack capacity to consent and older people. We're aware that most of the research at the moment seems to be on ethnic minority backgrounds, so we wanted to include that because we thought there'd be more chance of getting evidence, but also wanted to look at some other underserved groups. But due to resources, we had to limit the review somehow. Scope and review included papers that evaluated methods to improve the recruitment of these 4 underserved groups in the UK and Ireland. This led to a starter list of activities that we took to 5 different roundtables to identify what else was going on in the UK and Ireland to improve representation of underserved groups, which led to a large list of activities which were then used to theoretically redesign 3 trials with new stakeholder groups. And as I said, we're now interviewing the people who have experience of implementing some of the activities that we're going to talk about to explore how they can be implemented, what might be useful for further evaluation. So if you do have any experience of implementing these activities, do get in touch because we are still looking for participants. Now, I'll just give some findings from the Access Project. So the scope and review results, I'm sorry about all the text. I tried to reduce it. This is quite a busy slide. Only 8 papers came out of the review due to the inclusion criteria. which was UK and Ireland, reporting on randomised controlled trial recruitment and recruitment of an underserved population with some evaluation. There are a couple of similar reviews reporting on activities in the UK, but without an evaluation of the activities discussed. So now at the top right shows 5 of the papers were lessons learnt papers, which were either comparing recruitment settings or discussing different methods they use to successfully recruit to a trial. 2 of the studies were randomised controlled trials. 1 was across 5 trials and it looked at a £100 incentive, and 1 was across 1 trial looking at telephone follow-up after sending an invitation letter and sending a questionnaire prior to recruitment. There was 1 mixed methods evaluation of a consent support tool to support recruitment, and the underserved groups are listed here in the box as well. But it adds up to 9 because 1 of the papers looked at elderly and low SES. So on the left is the list of the categories that were discussed in the papers, quite a lot of overlap across the papers. Activities are grouped into the following categories. Recruitment sites, which here refers to where they are geographically, how diverse the areas are. 2 studies discuss choosing sites with targeted population demographics. Recruitment settings, which is the recruitment pathway, where you're recruiting from, so through GPs, community organisations, libraries and word of mouth. So that was in the studies in this review. 4 studies discussed 16 methods between them with a lot of overlap, and only 2 studies discussed 1 method in here. So that was consent support tool and a £100 incentive. All other studies discussed more than 1 activity for successful recruitment. Advertising was discussed by 2 papers where they did PR campaigns, including social media and printed advertising. Community engagement was the focus of sort of 3 papers where they discussed working with community groups, charities, local gatekeepers to identify participants, raise awareness and deliver the intervention. That does overlap with recruitment settings, but one of the papers is very said it was key to raising awareness in the community and making people more open to recruitment. Staffing was to improve trust between researchers and participants was mentioned in 2 studies, 1 in relation to employing bilingual staff to deliver the intervention, and 1 paper also highlighted affiliation with the university in their communication with elderly participants. Incentives were discussed in more than 1 paper but weren't evaluated in the others to the £100, so there were varied amounts of incentives. Trial design elements discussed in the papers included widening the inclusion criteria, where in this case they widened the inclusion criteria to include more frail patients so that they could increase their recruitment of the older people, and flexibility in appointments for recruitment and follow-up. Most studies discussed designing the patient documentation with their PPI groups or patient and public involvement. 1 did use a marketing company, and the consent support tool was evaluated to see whether it could determine the level of information needed for the participant to consent. So on the bottom right here is the findings for the activity that were evaluated. They don't match the ones in the box on the left because they weren't all evaluated. Lessons learnt paper tended to discuss more than 1 recruitment setting, method or activity, but they did not evaluate all of the things they discussed. For example, patient documentation or the design of patient documentation or flexibility. Evaluations tended to be around recruitment figures for different settings. Written invitations from GP and telephone follow-up are found to be effective methods of recruitment in elderly participants, but authors of 1 paper did state that targeted efforts could help with diversity. The £100 incentive improved recruitment, but not specifically for elderly or low SES groups, but just overall. Other studies that mentioned the incentive did not assess them. 3 studies reported that involvement with community groups helped with the recruitment, and there were recommendations to start this work as early as possible, developing a relationship with community leaders who can access via networks, newsletters or venues the underserved groups that you need to think about. Consent support tool was found to be effective at determining whether someone has the capacity to consent and what level of information should be used. While this paper highlighted some important and interesting activities being done, there's little reporting on their effectiveness. It was important to see what else was being done that hasn't been published and what those who conduct research and participate in it think would help overcome barriers that the populations face. So then on to the roundtables, which did not end up being roundtables. They were online, but we've continued to call them roundtables. There were 5 of them with 4 to 8 attendees each. Again, a mix of clinicians, trialists and patient and public representatives to explore their experiences and views on the activities from the scoping review and other activities that they know about or are doing. We captured the activities people suggested in line with the themes that came from the review. Many similar activities came out of the roundtables as in the scoping review. Were discussed in relation to a range of underserved groups, and there was a lot more suggestions, and many were repeated at multiple roundtables. So I've tried to list them again all here, and I'm going to just go through the additional ideas or ones that were stressed a lot at the roundtables. So multiple methods of recruitment were suggested to widen the pool of potential participants, and at the roundtables people specifically mentioned not going to research-ready sites, which seems common in multi-centre research. Community engagement was discussed a lot. You have to find out from communities what will work for them, and you have to help raise awareness of healthcare, not just entering and leaving communities for the sake of one project, making sure you keep people informed and trying to form bi-directional relationships to improve trust. Digital patient information was popular across all meetings. So you're using videos and animations instead of lengthy, complicated forms and information sheets, using layered information and starting with the information the participant cares about the most. Helps both for those whose first language is not English and those with low levels of literacy. It may even help with the ease of translation and interpretation. Tackling researcher biases came up a lot in our roundtables, talking about cultural awareness training and focused training on how to deliver a patient and public involvement. Unfortunately, we did hear examples of prejudice in healthcare and research settings, so some work with researchers did come up a lot. Ensuring ethics committees and research teams are diverse and aware of the barriers. So, for example, researchers type time limits. Getting through research ethics committees can be a long process, and this can make researchers reluctant to make changes to the way they do things in case it takes longer to get approval. So, yeah, some communication between ethics committees and researchers could be helpful. Also highlighted that ensuring diversity may not be the most efficient method for recruitment. Supported by one of the papers in the Access Review, where GP letters were the most efficient in recruiting elderly people, but the authors suggested more targeted methods could improve the diversity of the population, the ethnic diversity. Acceptance that more diverse samples might be slower to recruit is needed. There were also discussions around incentives, which are often put into trials. Most patients and publics thought it was more appropriate to think about it as the full reimbursement for their time rather than an incentive, using timely payment methods, including upfront payments, but also that other incentives might be more appropriate. For example, payment for being altruistic might be offensive in some cultures, and children might like certificates. I mean, mine would also like money, but they do like certificates too. And in terms of patient and public involvement and engagement, academics could offer training in research methods to help develop community or lay researchers who could then work on projects and supporting that bi-directional relationship. We then held 3 online meetings armed with this list of activities and the include frameworks, each with 8 to 12 attendees, again, clinician researchers and patient and public representatives. Sorry again for the amount of text. I wanted to show as many potential solutions as possible and have tried to reduce a bit of repetition. The 3 trials we looked at was drug trials in diabetes, an online cognitive behavioural therapy trial for depression through GPs, and a stroke physiotherapy rehabilitation trial set in a care home. As I mentioned, we had little information around the effectiveness of the activities, but the meetings we discussed effectiveness based on our experience, and also the potential barriers to implementing the suggestions. For example, the suggestion of upfront payment is difficult to implement due to payment systems, money could be wasted, and one of the papers in the scoping review said the incentive did not improve recruitment specifically of the underserved groups. Subgroup analysis suggestions that were made here were not actually discussed with statisticians, and there are issues around collecting the level of personal data that would be needed for some of these analyses. So as I mentioned, it can be quite a big job going through the framework. So the Access team, prior to the meetings, chose an appropriate framework for each trial, identified the barriers based on the previous roundtable discussions, and then suggested the activities to address the barriers. That was circulated prior to the meeting, and then we had a 2-hour meeting to redesign the trial with the whole groups. We considered more than socioeconomic status in the redesign meetings, but a lot of the suggestions also came up when we were developing the socioeconomic disadvantage framework. And at all of the redesign meetings, socioeconomic status was mentioned as a key factor, being linked to other underserved groups and a range of inequalities. We had recommendations for redesigning each trial, which might have been population specific or intervention specific, and I've tried to combine these elements to provide some general recommendations here, what you could consider putting into place to improve representation. Simple language and use of videos was mentioned in a number of areas, but as I said, I was trying to reduce text, so I've not written it in every box, but considering literacy across the board is important. The key is really making sure you're considering the underserved populations in your trial and working with the appropriate PPI and making sure you listen to the views of people with lived experience who are usually underserved. Saying that, people, I think, people are not the same, even if you're in the same underserved group. So trying to get a range of views from people who will need to be in your research, or speaking to a range of community leaders or someone that is happy to talk on behalf of a community is recommended. We're currently undertaking the implementation part, looking at barriers and facilitators, whether it does work, and then we're going to write some guidance for specifically aimed at trials units, but should help others. So here, there's a box on interventions here, and I'm now going to move on to talk about my other review that I'm doing, as that's related to interventions, complex interventions. So related to questions 2 and 3 of those frameworks, the 4 key questions which focus on the intervention, I'll briefly report on my ongoing scoping review. I've extracted some data, mainly from reviews, in relation to how people experiencing socioeconomic disadvantage have been included in complex intervention research, and suggestions for how to design interventions that are more inclusive. Brief background to complex interventions: they are treatments that have a number of interacting parts, such as behaviour change interventions, psychological or talking therapies, physiotherapy rehabilitation programs. They can be considered complex as there may be several parts involved. They could target a range of behaviours, they could be used in different settings, they could be used for different groups, and there may be skills required in delivering and receiving the intervention, and there may be some flexibility allowed within delivery. And I think this means that they can exclude more people than, for example, perhaps a simple drug trial, due to the language and burden involved. Complex intervention has 4 research stages according to the MRC framework, which is development, feasibility, evaluation and implementation. And looking at underserved groups is important across all of these stages. I wanted to do a scoping review to understand when and how underserved groups are included in the 4 stages of complex intervention research. Huge numbers of papers were additionally identified through scoping, over 40,000 papers from one database when I was looking at all stages and several underserved groups. Decided to focus on socioeconomic status, as it's linked to many inequalities and seems to be under-researched in the area of underserved groups. I want to find out how people experiencing socioeconomic disadvantage have been included in research around complex intervention. The review is still going and still extracting. I identified over 20,000 papers with my final search, so I limited the extraction to the last 2 years, screened over 4,000, and currently got 17 systematic reviews and 5 other reviews. All of these were evaluations of complex interventions, And then there were 119 other individual studies covering the stages of development, evaluation and implementation. Feasibility is included, but not seemingly as its own paper. It's often alongside development or evaluation. The individual studies are now choosing papers to cover all the 4 stages and to cover more detail of how people with socioeconomic disadvantage have been included. So from the reviews, how are people experiencing socioeconomic disadvantage being included? So the reviews and individual studies mainly focused on targeting groups that experience socioeconomic disadvantage. So they were focused on recruiting people with one or more of the variables associated with low socioeconomic status, as I've put here, so ethnicity, single parent, Medicare recipients, obviously in the US, not here, unemployed, low income, homelessness were ways that people were identified and included. A few reviews did look at subgroups within trials of larger interventions, and they generally found a lack of reporting on socioeconomic status variables, or that studies reported different variables, which makes analysis difficult. And this seems to be a common feature of research into socioeconomic status, is what variables are used and how it's measured. So at the end of the review, I hope to have a bit more information on that. And these were the bottom, again, the lack of reporting of socioeconomic status variables, but these were the ones that were found to be reported. So as I mentioned, the reviews were generally evaluations to see whether the intervention worked in groups experiencing socioeconomic disadvantage, or to identify the components of effective interventions. So here I've listed a number of the suggested effective components for the content and delivery of complex interventions, which are aimed at groups experiencing socioeconomic disadvantage, a lot of which came up in Access as well. Low literacy came up a lot. It was discussed in several papers. This includes general literacy, numerical, health and digital literacy. There's a lot to consider, and it can be very varied. Tends to be lower than the average in socioeconomic disadvantaged populations, and that needs to be considered. I think as academics and researchers, we use a lot of long words. We like, information is power, and I think that's an important thing to consider. So participants liked visual strategies, animations and photo stories, but it was also found that internet-based interventions were not preferred in a couple of studies for adults with low literacy, found them too difficult to use. In some of the reviews of nutrition interventions in particular, there was a common finding that educational-based interventions were not what is needed for this population. The problem is rarely the lack of knowledge around nutrition, and that interventions should focus on reducing costs and behaviour change methods. And ones used in education were not generally popular, felt patronising. Enhanced reminders and preparation cards were found to be helpful for participants in knowing what will be discussed at their next session and preparing for them. Mode of delivery is thought to be important. The telephone for housebound individuals was mentioned, home or community delivery, and no increase in clinic visits. But as I mentioned just now, digital literacy must be considered. Enhanced human resources as support for participation in the form of extra letters, more reminders, longer sessions of the intervention, just longer interventions in general. More contact with nurses and lots of time for questions and discussion. And that includes extended opening or out of hours sessions, so that people didn't miss work, for example. Important to people experiencing socioeconomic disadvantage, which should be obvious, I think, is making interventions low cost, providing necessary equipment and transportation to in-person sessions. Things that came up in the Access and the Socioeconomic Disadvantage Framework meeting were costs that are often forgotten, so costs around childcare, missing work, data plans and devices for online interventions. Lack of social support for people experiencing socioeconomic disadvantage was highlighted, and enhanced support during interventions could go some way to help with that, but it needs to be considered in interventions that do rely on social support. So these adaptations can also be, that were in relation to intervention design, but you can see that they can all be considered when designing trials, particularly those around literacy, access and staff support. So what's next? First of all, we need to have evidence that whether these activities work. To do that, we need to implement them. And to do that, we need to put funding into research proposals for this activity. As we discovered from the roundtables, people are doing these things already, but they are often not reported. We do not know how successful they are. Hopefully Publish and Access and this webinar will go some way to help get the information out there, but it now needs to be tested, reported and shared with others. There does seem to be a willingness from funders to fund this type of activity. What can researchers do? We need to really think about who should be included in our research, which can be difficult. Accessing information about disease burden across different underserved groups would be useful in knowing who should be in it. I don't know how to do this well, but we have been speaking to clinicians at sites about their patient populations. Clinicians do know about their patients, so it's always a good first port of call. The relevant data needs to be collected to know who's in your research and who is being missed, but that's often at odds with data protection, so there are limitations to that. And data around socioeconomic status is even more complicated because people collect different things. It's multi-dimensional. Researchers should work with diverse patient and public involvement when designing and conducting the research and can be guided by the key questions from the Include framework. The NIHR also has an equality impact assessment for research that can be used, which focuses on protected characteristics. There are issues with accessing healthcare for underserved groups, and our trials often run through the NHS, which makes it impossible to recruit participants that aren't in the healthcare system. So funders and researchers should think about the scope of their question, whether participants outside of the NHS can be recruited. We must consider what healthcare issues are important to underserved communities and work together with them to do trials that matter to them. Again, working with communities at this level helps with the bidirectional relationship needed with communities and researchers. So what can organisations do? During my fellowship, it's become clear that there's a lot of work going on in the area of inclusion, but often in silos, and it may mean repetition and research waste. For example, I've spoken to some local community groups that have been contacted by several people in the university, often discussing barriers in regard to slightly different elements of society, or it overlaps from their point of view, but we're all from a different university department. And reports that there's limited research into the solutions or moving past these barriers. We are unaware of the work going on in other departments, even in our own department, so collaboration and sharing knowledge around community outreach within the university would be beneficial for a wide range of researchers. One barrier that needs wider consideration than within research projects is educating the public about research to improve trust in research and researchers, making universities more accessible to the public, such as with open days, but also going to community venues and working with schools to increase health and research literacy, as well as potentially creating researchers of the future. There could be programs of work with universities helping to develop community researchers to improve the diversity of research staff. And then streamlining process such as payments. Payments often come up as an issue in the patient and public, and organisations usually have processes that mean they can take a while, and this is true of some other processes as well. So just to finish, here is some of my references and thank yous. I don't think you can actually click on those links, so I'm sorry, but my email is there and my Twitter. Please feel free to email me for any of these links. I've not included the references from the review or others that I've mentioned if they weren't written on the slide, but again, I'm happy to be contacted for anything. I do aim to publish these findings, and that will be shared on my Twitter as and when it happens. Thank you to my pre-doctoral supervisors, Alicia, Cindy, Liz and Heidi, the Trial Methodology Research Partnership and Sean Trewick, and the collaborators on the Access project. You can see our website for more details. Can't click that. Fran, who I think is here, and Heidi for our work on the Socioeconomic Disadvantage Framework. The DPEND Patient and Public Involvement Panel have been really helpful throughout my fellowship so far, and Dr. Kate Fryer at the University of Sheffield, and of course all the Access participants. Some of you may be here as well, so thank you. And that's, I'm happy to have questions, I think. Angie?
Okay, thank you very, very much indeed, Katie. I'll just I'll leave your slides there for now, just in case you need to refer back to them for any of the questions that we'd had, and I'll just pop back to the chat. So we'd had a few questions. Robert, you'd asked a question about asking about examples or other work looking at those who are underserved outside the classic reasons you've included here. Danny Hind has responded to you there with a link, so I hope that, I don't know if Kate was anything, but Danny has responded and answered that question. So hopefully that's okay. Fran had asked a question about the Access Focus Group, and Katie had very helpfully replied saying that she'll email you directly. So that leaves in the chat a question from Alexandra, which says, much of the focus here seems to be on engaging with adults. I'm from Sheffield Children's and leading on the development of our research strategy, particularly interested in how we increase the diversity of children involved in our clinical trials and wider research. Children have some specific barriers, examples here, time away from school, parental interest, willingness to engage, impact on the wider family, e.g. if there are other children who have to be looked after while the child is participating in research, etc. All of these are exacerbated by the kinds of language, socioeconomic barriers you described. Did your review pick up any specific issues around how to widen access for children?
Unfortunately not. There wasn't any. We are quite aware of this research gap, and I think it's a big research gap. The focus has definitely been on adults. Also, it sort of seems to start with minority ethnic groups, and is now sort of widening into other underserved groups. So I'm hoping it will come. I do think some of the work with adults would help with the children's, because you normally need adult consent as well. I'm also doing some work with the Children's Hospital to talk about this, and we are hoping to sort of visit some schools. But no, it's a huge research gap, I think, children.
Okay, the next question in the chat before we go to Cindy, who I can see has got a hand up, was from Octavia Wiseman saying, what would translation and interpreting come under? I think this is referring back to one of your previous slides, Katie.
Yeah, so I think because my my webinar was more focused on socioeconomic status, I didn't really go into that, but that is something that comes up a lot when looking at the sort of ethnicity underserved groups by ethnicity. Interpretation and translation comes up a lot, so I think it would sort of come up under the simple language and communication, making sure that consent process is understandable, and making that simple language would make translation and interpretation, I think, also a little bit easier. Interpretation and translation comes up a lot in access to trials, but not necessarily in socioeconomic disadvantaged groups. So that's why I didn't focus on it. But it is something we're putting into trials a lot now. We're costing for translation and interpretation, but again, we're not quite sure how much is going to be used or how effective it will be at recruiting more diverse participants.
Okay, thank you. Cindy, I can see you've got your hand up. Did you want to ask your question?
Yes, it's actually in response to, is it Alexandra? It's interesting you say you're interested in including children in research, as we've got Katie and I are advertising a University of Sheffield scholarship in trying to improve inclusivity in children's research. So it would be quite good if we could have a chat maybe. I haven't got your email on there, but if you contact Katie, it'd be good to talk about that, including children in research.
Okay, thanks very much. The next question in the chat was from Liz Williams, who says, can you explain what the consent support tool looks like?
Oh, unfortunately, I cannot. I just read the paper. Didn't look. We are using it for one of our stroke trials, though, but I don't actually think I've seen it in detail. But it goes through levels. It is about the language and whether people can understand different levels of sentence, and then what they understand from a sentence shows how much they have the capacity to understand the information of the involved in the research. So yeah, sorry I can't give a bit more detail, but I'm happy to send you the paper, and I'm sure I've got the tool in a folder.
Okay, last question in the chat at this point is from Robert. So he asks if your two scoping reviews have been published yet.
No, and I am going to do it. I'm working on it.
Okay, that's all the questions in the chat so far. If anybody else has a question that you'd like to ask, do you put it in the chat now? I think Dan has turned the mic option on, so if anyone has their mic on and wants to ask a question, please do so. I'll just quickly now move back to the last slide just to finish off whilst I wait to see if anyone has any final questions. So just to remind you, at the beginning, Claire mentioned about the courses, some of the postgraduate courses that we run in ScHARR. Do get in touch if you would like more information about any of those. For any general inquiries, obviously there's an email address on the screen there as well. And also, I think Claire mentioned a little bit about some of the short courses that we run. So we'd love to hear from you if any of you would be interested in studying with us. I think, do we have another question from Anil? I can see you've got your hand up.
Yeah, I joined a bit late, so can I get the PowerPoint slides later on being circulated? Presentation will be circulated later on because I joined a little bit late.
I don't know, Katie, whether you're happy to. Oh, Dan's just saying that he's made.
Yeah. I think it's been recorded, but I'm happy to share the slides as well. But the recording is.
That's wonderful. Thank you.
Okay, fantastic. Did anyone else have any questions? I can see there's quite a lot of people still here.
Hi, can can you hear me?
Yes. Yeah, we can hear you.
Hi, I'm Bea. I'm one of the research nurses at the Children's. I didn't get hold of the name of the lady who said that she'd be interested in talking to Alexandra Norrish, but can I be included in that as well? And we also have a PPI, member of staff who would be interested. I'm not sure that Maniba's on this call, but that would be good if we could be included.
I'm in touch with Maniba as well, so I'm sure. Yeah, we'll make
who is that? Katie?
I'm Katie, but it was Cindy as well. Cindy.
Oh, it was Cindy, yeah. But I'm sure Alexandra will include us. But that would be great. Yeah. Thank you very much.
Okay, thank you.
And Mark did say the consent support tool is the one that was developed by our very own Rebecca Palmer and others.
Okay, did anyone else have any final questions? Thanks for that, Alexandra. I can see you just put a message in about following up with an email. Okay, well, thank you everybody for coming along today. Thank you, Katie, obviously, for giving a really great webinar, great start to the new year for us. Thank you very, very much to everyone who came along, and obviously we'll be making the recording available later on as soon as it's ready. But thanks very much to everyone for coming along, and hopefully we'll see you at another masterclass at some point in the future, and maybe even on one of our courses or short courses.